So I know you guys have asked some questions already. Does anyone have any questions?
Okay, so I'm thinking about revisiting a chemo that didn't work the first time that I did it. In 2013. And sometimes revisiting a chemo is okay if there's been enough time. But if it didn't work the first time, is there any sense in me wasting my time to do it again?
It depends on the type of tumor, biology of the tumor, and how good a response you had the first time. If your response was 6 months to a year, I would say there is some sense in revisiting the same drug. But if that is not, usually the responses are much smaller, and you're better off if you have exhausted all the chemotherapy options to go to a clinical trial.
Yeah, because I only have one other chemo left because I've done everything else. And I thought if I retry FOLFIRI with Avastin, but I thought it didn't do anything the first time. The cancer actually spread. So what is the point in me?
So you had FOLFIRI Avastin first, very short interval, followed by FOLFOX Avastin, and now they are thinking back on FOLFIRI Avastin.
Yeah, I suggested it to my oncologist. I said enough time has passed. Is it possible that it will work?
But the issue is if you had less than 6 months with the first FOLFIRI Avastin, you're bound to get much less than that the second go around. So I would not recommend that.
Okay. So would you?
I would go on to other drugs. There are newer drugs available. You have regorafenib. You have another called the trifluridine.
Well,
There's another oral drug.
And there's my oncologist refuses to prescribe Stravaga because he doesn't like it. And
Stravaga is a little bit of a tougher drug to take.
Yeah.
So it's not unreasonable not to offer it, but you can discuss with them. There are other fewer agents, but what the other option, especially if you are doing really well, is to consider maybe even a clinical trial.
A clinical trial versus trying like Lonsurf.
Lonsurf and things will have a much, and the regorafenib Stivarga will have a much lower response rate.
Does it matter that that I'm MSI low versus?
The MSI low, the only difference is we cannot do immunotherapy. If you're MSI high, we could have done an immunotherapy. Since you're MSI low, one option also to consider is maybe do something like a Foundation 1 medicine. Just test the tumor and see if there is any other weird mutations that come up which can have, drugs that we can attack the tumor with.
Okay.
Especially if the distance is a matter and you don't have any access to clinical trials locally, that would be a good option.
Okay.
I just want to say that in 2014, I was very fortunate to get to see both Montri and Shaheen at the seminar that had at Methodist. So I was so glad to see you again today. But I want to ask you, Dr. Is it Kanan?
Kanan, yes.
Kanan. When you were talking about breast cancer, you talk about estrogen positive, and
HER2 positive, and then the triple negative.
Talk about all the negatives. I'm estrogen positive and HER2 negative.
Right.
But they don't talk too much about that combination.
Most postmenopausal women are estrogen positive, progesterone positive, HER2 negative, which is very common. Tend to be a little bit more, especially in postmenopausal women, tend to be a little bit less aggressive. And with you being hormone positive, ERPR positive, gives you the option of treating with pills. You have Faslodex, you have Ibrance, all of those combinations which can be used.
I used everything that was available to me back in 2015, and I've had to go back and...
You can actually go back and revisit.
I did. I stayed on
you can
Xeloda for
recycle
19 months, and then he changed me 3 months ago to the very first one I took in 2014.
Yes, and you have options of adding other agents, like you have the CD3, CD4 inhibitors, which you can add on, medicines called Ibrance.
They kind of took the estrogen blockers away from me because there were studies that sometimes showed that they inhibit the chemo from working as well. Is there any?
Usually not. When patients are initially not very, very symptomatic, metastatic breast cancer can go on for years and years and maybe decades. And the hormone-positive breast cancers, typically what they do is they tend to metastasize to the bone alone, and those kind of patients tend to do really well. So what we do is, like I mentioned, so everything is about sequencing, and you can start off with hormonal agents. go from steroidal to non-steroidal, then come back to steroidal. You can do this again and again until the disease really progresses and you have systemic disease like maybe liver or lung, in which case we can even add oral drugs on top of it before even we go to chemotherapy. So there are patients who don't see chemotherapy for years and years. So the chemotherapy is only when the disease advances enough that we need something more than what we have with conventional drugs, the hormones, to reduce the intensity of the disease. And then once we control it, we can always go back on hormones. So it's more of a dance of figuring out what is the best regimen for you and which gives you the least side effects. Because we don't want to win the war and lose the battle.
But I will be 8 years stage 4 terminal in March.
You look fantastic, and I suspect that if you're still on hormones, you can go for several years on hormones. And if
Get
you
me off of those.
okay, so you're off of hormones and you're not on any treatment?
No, I'm doing treatment.
Okay. But what I'm saying is there is always a possibility of going back on hormones. If you have purely liver-only disease, you have the option of SIRT, the selective internal radiation. But if the disease is elsewhere, bone-alone disease is not as worrisome as lung or liver because
I have
those
bone and liver.
bone and liver, but there is an option of possibly treating the liver with things such as SIRT, the selective internal radiation. Data is not robust, but it's not FDA approved, but it's still doable. And then you can always go back on to chemotherapy or control it on hormones. The bone is not the biggest problem.
Yeah, I've been on Avastin going on 8 years.
Okay.
But we watch those kidneys real close too.
Looks like you're doing well.
Thank you.
I'm curious, I have stage 4 colon cancer, and I've had 2 oncologists now tell me that there's no cure, but I've had other stage 4 colon cancer friends that have said that they've been told otherwise. So why is there such a mixture of...
I think the issue is semantics. When the cat is out of the bag, like I mentioned, it's very hard to put it back in the bag unless you have single or smaller lesions in the liver which you can cut out. So that would be a curative resection. If you're not a candidate for curative resection, you may be treated and not have any disease present on any imaging, but that is just called remission, but that's not called a cure.
Okay.
So people say you're in remission, and you can stay in remission for a long time depending on your disease biology, but we cannot say it's a cure because once the cat is out of the bag, you can never put it back in a bag.
You. Because I'm just now doing the chemo to take care of what has come back into me after having a 1 centimeter that came on the wall behind my uterus. And when it came back after all the radiation was out of me, bing, bang, boom, it hit me, My liver now is showing that I have cancer in the top layer. Yet the radiologist said we only took the 2 largest to give the rest, because the rest was just a lot of little ones. Can you go in there and get rid of those 2 biggest ones, and will it still treat whatever little ones floating on that top layer with that Y90 or microwave or whatever? Do you know what I'm kind of saying to you? Okay.
What type of cancer? I'm sorry.
Small, stage 4, rare, small cell. I can't ever say carnomosa. And I've been fighting it ever since 2015, and it's gone away. My bladder is completely clean. I mean, I just had that done just the other day. He said, it is beautiful. My heart is like someone that the doctor has not seen in many, many years. It is perfect shape. Nothing is wrong with artery. It's clean. And I survived blood clots in my lung from chemo of platinum at the first treatment back in 2015, and I should have been dead. Because what I had in my lung, my doctor said, you should be dead. No one survives that. And I said, God's not ready for me. I am a strong, strong person. I am very athletic. I do not like to sit around and watch TV. And I am determined to find a cure for a rare cancer. Could this help me with my rare cancer?
So, unfortunately, we don't have as much data with other types of cancer outside of hepatocellular carcinoma and colorectal cancer as much as other cancers. So the answer is possibly. It's not definitive. I can't tell you that for sure would be able to help you. I think, we probably need the full information. We need to look at the scans. We need to find out exactly what type of tumor it is, and, try to find out where the origin is. And I mean, I'll tell you, just sometimes similar to small cell is like we do get a lot of good results with the neuroendocrine patients. And that's something that we have experience with. So if the tumor is similar to neuroendocrine tumor, then chances are you will get a response. But with that being said alone, I don't know about, like, I'll tell you that some tumors that have been very difficult for everyone to treat has been pancreatic cancer. And pancreatic cancer is a very difficult tumor, even for Y90 radioembolization. Those tumors are the toughest.
Well, I hope it never travels from my pancreas.
Yeah, and those patients that come to me and they have liver cancer, mets from pancreatic carcinoma, I usually I've been passing on those patients because we have not gotten good results, and I don't want to put anyone through a procedure unless I feel like I can help them.
Well, I do know that because I'm getting ready to do my last 5 days of chemo by the 15th of December, and we're going to do another CT scan to see. He snuck one in just a couple of weeks ago and found out that some is shrunk, some is like down here somewhere, down in the lymph node or something. It's shrunk. Some is stabilized, but the two that's in the liver grew just a little bit more. And that's the one he said, not that much, he said, but he said it's okay. And my liver count is going down. And I'm just, I after we get through this chemo, because I have already done 2 drugs, research drugs, and neither one touched me. In fact, one caused more trouble to my liver. And I'm going to introduce him to this next process and see what he wants to do with me, and whether Texas Tyler Oncology does this, because they do have a research there in that building, and can do, if there's doctors here that can do what you can do here in Tyler, or would he need to send me to you? Could that happen? Can I do that? Just say, hey, I want to transfer my records over and see what you can do for me.
It's always, a lot of times, if you're not getting the answers that you need, I always recommend getting a second opinion. Doesn't necessarily have to be at Methodist Dallas. Could be anywhere that just has experience with all the different modalities. And I would certainly highly recommend that.
Okay. And just one question to you there. Do you have a book out about having happiness?
About what?
A book out to make happiness in your life when you have cancer?
I am definitely working with a couple of different patient advocacy groups, because they're real tools that people can practice that make it just a little bit easier.
Oh, I'm a happy camper, so I love happy books.
Yes, on the liver, with that Y90, will that work on other cancers as well? It looks so interesting and so easy. It'd be so easy if we could just isolate it, go in there, shut it off. Is that possible for other cancers to be treated the same way?
Or is it only for the liver?
So you mean other cancers outside of the liver, or you're talking about?
Yes, outside of the liver.
So for Y90, the approval is only for the liver right now. There are people that are doing some research. I think they're kind of like case reports, I've heard, that are looking at kidney and lung, like I mentioned. But it's really not FDA approved. We can't advocate it. We don't do it. They're more like research institutions that are doing them.
They are doing them in research?
Like clinical trials?
I don't even think that it's reached the clinical trial level. I think it's more like, okay, this is a last resort. We're going to do this because...
Great success. I mean, it looks so simple, just so...
Go
Yeah,
go in and hit that auricle and that vein and that vein and that vein and pop them all out.
I mean, that was perfect. That is just so what we all need.
Yeah,
To isolate it, keep it from transferring from another organ. If we could encase it to where it's not spread outside of that.
What makes the liver a little bit more special and allows us to do all the stuff that we do on it is because it has that dual blood supply that I talked about. So it has, 2 vessels that are feeding it. So if you block off the artery, you still have the portal vein. That's unique to the liver. So that's why you'll find most of the treatments that involve the arteries involve the liver. But that being said, we have other approved, kind of treatments that we do outside of the liver, like, the kidneys I mentioned and other solid organs, even bone tumors. We have treated spine tumors with radiofrequency ablation. Those probes that we go in and we heat tumors, or cryoablation, we've done that. But for Y90, for now, for the most part, it's just specific to the liver, except for, experimental type of in research institutions that are doing it.
That's very helpful. Very encouraging.
From a caregiver's point, I've never run across a navigator or whatever you called yourself. Is that something that's becoming more prevalent for, like, we're from Hot Springs, Arkansas, and do you have to come to a place like Dallas or somewhere down here to gain your knowledge and your benefit?
Not necessarily. So I think in 2015, the Commission on Cancer required that all accredited cancer institutions have nurse navigation. So it depends on if the cancer center is accredited and who they're accredited through, what those certifications are, because there are some that require it. But I'm not sure what's available in Hot Springs specifically, but we can talk about some resources that might be available in that area.
Thank you.
Hi, I'm a colon cancer survivor, but before I had colon cancer, my sister had breast cancer. So I became part of the sister study almost 20 years ago. And I would like to ask you as a team about your opinion on tamoxifen and like drugs, because the studies that came through the sister study is that the risks were not worth the benefits. And state-of-the-art teams, I just kind of wonder where you're standing on that.
So did you have a diagnosis of breast cancer?
No, my sister.
Sister did. So tamoxifen and other things to prevent cancer from coming back, it's called adjuvant therapy, highly beneficial in most women. I assume she is premenopausal since she offered tamoxifen or as weak bones, but tamoxifen or other agents, in postmenopausal women, things like aromatase inhibitors, will prevent the risk of cancer coming back by about 30 to 40%, which is huge. So there is risks to anything we do in life. There is a risk to crossing the street. There is a risk to coming to a conference. There is always risk to things in life, but the risk-benefit ratio tips more towards tamoxifen. There is a small risk of blood clots, very small, 3%, which means 97% you don't get it. There is a very small risk of getting endometrial malignancies, possibly. Patients can present with bleeding. Risk, again, is less than 5%. There is a small risk of blood clots and things like that, but overall, the needle is tipping towards the benefit much more than the risks, if that helps.
Another question. Is there any studies that would indicate that if you have a Crohn's disease and you get a colorectal cancer, that the treatment should be different than maybe other root causes for the cancer, for colon cancer?
Not that we know of. Crohn's disease, of course, can predispose you to have colorectal malignancy, so surveillance would be key to prevent cancers. And Dr. Mantri can talk more about it.
Well, the colon cancer, which occurs in Crohn's disease, typically arises from a defect in the entire lining, and therefore we would remove the entire colon. That's called as a total proctocolectomy, and then the surgeon would attach the small bowel to the rectum if the rectum is not involved. With Crohn's, you can do that. In ulcerative colitis, we just remove the entire colon and the rectum and create a pouch. But otherwise, there's no such specific difference. Again, when colon cancer arises in the absence of Crohn's disease, you can just remove a part of the colon. And Susanna, do you have any input on that?
I'm going to agree and disagree a little bit. For ulcerative colitis and cancer, that's true. It would be a total colectomy. But I think for Crohn's, it could still be a segmental colectomy.
I just want to say that y'all are an amazing team.
Yeah.
And I was diagnosed 2.5 years ago with multiple myeloma, but it's been a good journey. It really has. I've been on chemo, and I just wanted to say that at the beginning, I did pray and ask the Lord to send me the best oncologist, and she is the best. But today what happened was I got information from y'all coming forth, which was great because I didn't know a lot of the stuff, even though it was mostly on the liver. But the fact is y'all said some things that confirmed to me that she is the best, because she keeps informed at conferences and goes to things and comes back with things, and the importance of asking questions, and everything. And so I just want y'all to know, to say thank you, that y'all, God used y'all to confirm some things to me that I needed to hear. And just want the young lady at the end talking about the joy, and it's like, for me, the joy of the Lord is my strength, and all the things that you said in there just add on to it. So thank you.
Oh, amen.
This whole team gave up their Saturday mornings just for us. They don't get paid for it. It's from the goodness of their heart. And they have answered emails in the middle of the night, phone calls all the time. And I can't tell you how much I appreciate the fact that you're here, and the fact that you're so close to me just makes it even that more important. So thank you for being here. And as a small token of appreciation, this is a plaque for your team. And so